Hi, it's my pleasure to introduce this year's speaker for the Gray Foundation Memorial Address. My name is Andrew Bradley, the current chair of the Gray Foundation. This year's speaker is Professor Ashley Blom of the class of 85. Ashley and his wife Catalina are funding a number of bursaries at the school. So thank you for your generosity and your expertise, which you are sharing with us today. Ashley is the head of the University of Bristol Medical School, an NIHR senior investigator, and a fellow of the Academy of Medical Sciences. He leads the analysis team of the National Joint Registry for England, Wales, Northern Ireland, and the Isle of Man, which is the largest registry of joint replacements in the world. He also leads the orthopedic work streams into surgical innovation in the University of Bristol Biomedical Research Centre. Ashley is past president of the European Orthopedic Research Society and is a member of both the Education and Specialist Societies Committees of the European Federation of National Associations of Orthopedics and Traumatology. Ashley and the team in the Musculoskeletal Research Unit at the University of Bristol have recently completed a first-in-human study using stem cells to heal meniscal tears in the knee. So thank you, and over to you, Ashley.
Thank you for asking me to speak at our reunion. It is a great honour. Our thoughts go out to Andrew Auld, who's a very dear classmate of ours from the class of 1985, who's been a great leader and a great friend. And Andrew, unfortunately, is extremely unwell with COVID-19. And our thoughts go out to Andrew. We look forward to seeing you make a good recovery. As mentioned, I am a member of the class of 1985. After graduating from Grey, I studied at UCC, studying medicine. And then in 1994, I emigrated to the United Kingdom and trained as an orthopedic surgeon, specializing in joint replacement, particularly hip and knee replacement. Whilst undertaking my orthopedic training, I did a great deal of research, and including 2 doctoral degrees, an MD and a PhD. And the research was very interesting, involved things such as inventing and trialing a form of artificial bone, biofunctionalizing titanium in such a way to make it resistant to bacterial colonization, undertaking first-in-human studies in stem cell therapies. But mainly what I did was large programs of research into improving joint replacements, especially the safety thereof, decreasing and treating complications, and increasing the longevity of implants. This work had a marked international impact and featured widely on international television and print news, and was cited in international guidelines of the European Union, many national guidelines, the Food and Drug Administration in the United States, the MHRA, which regulates medicines in the UK, and bodies such as NICE, the National Institute for Clinical Excellence, which advises doctors on how best to practice medicine. And as a result of this, I was elected as a fellow of the Academy of Medical Sciences, made an NIHR senior investigator, which is the college of the supposedly leading 200 clinical researchers in the UK, and then became president of the European Orthopedic Research Society. This led on to me being made head of the medical school in Bristol approximately 2 years ago, which was a fantastic job, and I was very excited about this. In the school, I have over 1,000 staff members, 600 of whom are researchers who do really world-leading research in a wide range of areas. We have over 2,000 students and an annual budget of about 1.8 billion rand. So far, so good. And then COVID struck and the whole world changed. COVID is a coronavirus like flu. It normally infects bats, but at some stage it crossed from bats to another animal vector and then on to humans. And we strongly believe this happened in the wet food markets in Wuhan in China. Now, those of you who have been to China and have seen the wet food markets, and they're called wet food markets because the animals are sold alive as opposed to most markets where the products of the animal are sold. In these wet food markets, they have a wide variety of animals, many animals which we wouldn't eat in the West, and they're kept in very close proximity in cages. And so, for example, you'll have snakes, scorpions, bats, a number of other animals, all kept very closely together. Now, they don't normally intermingle this closely in nature. And so what happens is that infecting agents like prions, viruses, and bacteria can leap and cross-infect across species. And we think that this is what happened in Wuhan. It went from bats to another vector and then on to people. And the Chinese tried very hard to contain the outbreak within the city of Wuhan, but despite this, it spread. And really, we shouldn't have been caught by surprise that we ended up with a pandemic, because pandemics are common, but unfortunately we were caught by surprise. Remember, in 1918 to 1920, we had the H1N1 pandemic, known as the Spanish flu in most countries, and known in South Africa as the griep. And it was called the Spanish flu, not because it arose in Spain. It arose in the First World War in the trenches amongst the soldiers. They were very immunocompromised because of the conditions they were in and the things they were subjected to, and in very close proximity. Of course, no country wanted to admit in its national newspapers that the soldiers were falling very unwell, but when it spread to nearby Spain, Spain was not in the war, and they did report it in the newspapers, and hence it was called the Spanish flu. Now, people were not very mobile in those days. They didn't fly all over the world, but at the end of the war, all these soldiers went home to their various countries, taking H1N1 with them. And H1N1 is just a variation of flu. By 1920, it had killed 50 million people worldwide. Now, COVID-19 to date has killed about 4.7 million people. So you can understand the scale of H1N1. Since then, we've had a large number of other pandemics. We've had AIDS, SARS, MERS, Ebola, swine flu, and avian flu. Ironically, the most deadly of these are often the most easily contained, and Ebola is a good example of that. Because Ebola makes people so sick so quickly, other people will avoid the people who have it. And then secondly, Ebola tends to kill people very quickly, so they don't have an opportunity to spread the virus widely amongst a large range of people. COVID is not as deadly, and it spreads via the oropharyngeal route. So if you cough or sneeze or speak, you spread the virus. And you can imagine in public transport, for example, if you're on a train or a bus and one person is either coughing or sneezing, the virus can survive outside the human body, not for a very long period, but it does survive. And you can cough on surfaces, people touch the surfaces, they touch their face, and they have the virus. So after it left China, it had a very large impact in northern Italy and Spain. And we in the UK were noticing these alarming reports coming from our healthcare colleagues in these countries. Huge mortality rates, particularly amongst the elderly, and the hospitals were quickly totally overwhelmed, especially their ITUs. They had shortage of incubators, shortage of personal protective equipment, shortage of specially trained doctors and nurses, and shortages of things such as oxygen. It then entered the UK via multiple routes, mainly from holidaymakers in the Alps who'd been on ski holidays and then flew back to various cities in the UK. So it didn't enter via a single person or via a single city, but at multiple entry points at the same time. And then the UK government, along with many other governments in the world, were faced with a dilemma on how to proceed. We didn't know much about the virus, we didn't really know how to treat it, and certainly there was no form of vaccination. And the dilemma was really, should you try to contain it by heavily shutting down your country, stopping movement of people, stopping interaction? But that would shut down your economy. And we know if you shut down your economy, the poor suffer the most. Now, the greatest indicator of early mortality and ill health is being poor. So if you shut down your economy, it will lead to the deaths of many people. The alternative is to try herd immunity. The idea that the virus spreads through the community, a lot of people will develop immunity, and once you get to the stage of about 80% of the population having immunity, it becomes very difficult for the virus to spread further. Of course, that would involve large numbers of deaths. Most governments went for neither of these two extremes. What they tried to do is to have some form of limited containment that flattened the curve. And the idea behind flattening the curve was that the hospitals in Italy and Spain were swamped because they had so many patients at the same time. And if you could just slow the spread of the virus, hospitals would still have large numbers of patients, but not at the same time. And then the question came up, could we flatten the curve until a vaccine was available? So if we could flatten it low enough and long enough, maybe a vaccine could be developed. The problem is that vaccines take years, sometimes decades to develop. You have to sequence the genetics of the virus. You need to develop a vaccine against certain proteins in the virus. And then you need to check that this elicits an immune response in people. At that stage, you can run safety tests. And safety tests normally take years to run. And the reason for this is that years ago in the UK, in London, they ran a trial of a new drug. And they tested it on a group of young, healthy volunteers. All the volunteers were in the room. They injected the drug into the first volunteer and then slowly went around the room injecting it into all the other volunteers. After a few hours, the first volunteer became profoundly unwell, ended up in ITU, and followed by the second, followed by the third. And most of the volunteers became extremely unwell and some died. The learning point from that is that when you want to test the drug safely, you need to leave long periods between individuals. So normally you test it on the first individual and then leave weeks before the second, even sometimes months. And I'm involved in a stem cell therapy trial at the moment where the NIHR have allowed us to test it on 10 individuals, and have insisted that we follow them up for 7 years to check that there are no long-term safety implications. Once you run your safety test, you need to run efficacy tests, see whether it works, and that's using on lots of patients over a long period. Simultaneously, you need to upscale and optimize the manufacturing. Just because you can make it in small doses doesn't mean you can make it on an industrial scale. And in this case, you need to provide enough vaccine to vaccinate 7 billion people on the planet. You need to produce it and administer the vaccine. And there are real problems with that. Most of the vaccines, and I'm jumping ahead in the story a bit here, need to be stored at minus 80 degrees. Not many facilities have minus 80 degree freezers. In the manufacture, they ran into simple problems. There simply weren't enough high quality glass vials to put the vaccines in. And there were problems with international cooperation and unintended consequences. For example, at one stage, the US realized that a lot of the things that you needed to produce and invent vaccines were in short supply, so they stopped exporting them. There was an export ban from the USA. Most viruses in the world are in fact made in India, so India had a shortage of the equipment it needed to develop the vaccine, which of course then had a knock-on effect back on the USA. So there were some unintended consequences, well-meaning but unintended consequences from national governments. Meanwhile, in the UK, the numbers are rising very, very steeply. And we quickly learned some really important things, many of it through international cooperation and sharing knowledge between countries. We learned that pro-nursing made a big difference. It would seem really counterintuitive. If you've got a bad respiratory infection, why would you be nursed face down? But doing that actually helped the lungs to cope much better. We also found that simple things like using steroids such as dexamethasone made a big difference. Again, this seems counterintuitive. If you have an infection, why would you give somebody a drug that decreases their body's ability to mount an immune response? But what we realized is that part of the problem was a very over-exuberant immune response in patients' bodies, which were in fact making the patients sicker. And so the dexamethasone was helping control this. We also found out who was at risk. Mainly the elderly, the overweight, those with other serious medical conditions, and people from Black and ethnic minorities. So quickly, our hospitals were full. In the UK, we were seeing 60,000 new cases every day, and we're having 1,500 deaths per day, despite being in lockdown. So this was the flattened curve. We didn't have enough ventilators, we didn't have enough hospital beds, we didn't have enough of the right kind of doctors and nurses. I'm an orthopedic surgeon, I do hip replacements. I do not know how to look after a patient on a ventilator, so people needed retraining. We didn't have enough PCR machines for testing, we lacked quick and accurate forms of testing, and we didn't have enough PPE equipment, which means that we were putting the lives of our staff at risk, and when staff were becoming unwell, they could no longer treat patients. In Bristol, like many cities in the UK, we built an emergency field hospital. In China, they built entire hospitals from scratch in a short period of time. We seconded all our clinically trained staff from the university to the NHS, and we had people who hadn't practiced clinical medicine for many years suddenly on the front line. We brought doctors and nurses out of retirement. Our medical students were trained as healthcare assistants and did nursing shifts, often looking after the most sick patients. We stopped all non-emergency care, including elective surgery, and we retrained doctors like me, who are surgeons, so that we can get crash courses, often trained by the junior doctors, in how to treat medical patients. And then our physicians were often looking after the COVID patients, and our surgeons looking after the other medical emergencies. We repurposed all of our university buildings to house the NHS support staff and the vulnerable clinical staff, so they didn't have to physically be in the hospital unless they really had to. And we provided a great deal of lab equipment, including ventilators. And being a university, we have a vet school. The vet school has ventilators when they treat animals, so we could repurpose some of these from human usage. And we had PCR machines, which we used for research, which we gave to the NHS. And then some simple things. Our chemistry department realized they could manufacture industrial quantities of sanitizers, which they provided for schools, for city council, and for the hospitals. But I think the biggest thing we did in Bristol is that we swung our research expertise into fighting COVID. Because we had all these wonderful researchers, very intelligent, with huge knowledge in other fields, which could be repurposed. So some examples, working with Milan, we developed a rapid and accurate test for COVID. We worked closely with Oxford and the AstraZeneca team in helping trial their vaccine. And I'm very proud that Bristol was the city that recruited the most patients to the vaccine trial. We worked with the Bristol City Council to measure the impact of COVID on children's well-being and education. And this has had a profound effect, and it's going to take decades for this to work out the system. And the World Health Organization approached the University of Bristol and said they wanted to run a very large multinational trial with a huge amount of patients testing the various treatments that are available to COVID. And because some of the researchers in the medical school in Bristol had particular expertise in designing these complex trials, they had the team in Bristol design the trial for them. And this was an extremely good trial published in the New England Journal of Medicine, the foremost journal in the world. And we seconded some of our experts to sit in advisory panels for the government. And certainly one of our virologists is one of the major advisors to the UK government. Of course, we're a medical school and we have to teach people. And you can stop teaching during a pandemic and tell people we'll just teach you a year later. But you can't do that in medicine because there's a pipeline. And if you don't turn out next year as doctors, the NHS will fail. So we had this difficult situation where we had to move some of our teaching online, but continue with some of our clinical teaching in the hospital. And we were very innovative in moving things online. Fortuitously, for the last 25 years, we'd been recording interviews and consultations between doctors and patients, covering a huge range of diseases. And we put these online for every medical student in the UK, regardless of which university they were at, to be able to watch and see these consultations. So if your hospital was, for example, no longer treating people with osteoarthritis, you could log on and watch the interview and see how the doctors interacted with the patients. But of course, as I said, in the clinical years, you can't treat them online. And so our medical students stayed on the front line in the hospitals to bolster the workforce and to ensure that the next crop of doctors were available to start in August. It worked so successfully that we actually managed to graduate our final year class early. And so they started the NHS 6 months earlier as an additional workforce to help out our local hospitals. And then two miracles happened. Number one, containment did work. We did manage to flatten the curves. The hospitals were not overwhelmed. Our emergency field hospital that we built at vast expense was packed up and closed down because we didn't need it. And multiple vaccines were developed that were effective and extremely safe. Most of these vaccines give 80 to 90% protection from disease, as well as excellent protection from severe disease and mortality. And importantly, those who are vaccinated, if they do get coronavirus, are much less likely to transmit it, so it becomes less transmissible. We do know that the immunity from vaccination wanes with time, and the estimation is that after about 6 months of your second dose, your immunity will be down to about 60%, and so many governments are now moving towards giving boosters to the most vulnerable people and to healthcare workers and the elderly. There's also been really exciting work coming out of the United States recently that's showing that the vaccines are safe in children as young as 5 years old. So currently in the UK, we don't have any lockdown at all. There's freedom of movement. People have returned to face-to-face working. All of our children are back at school. And so our cases have gone up again. They dropped from 60,000 cases a day down to only a few thousand. They're now up at about 30,000 cases a day. But because of vaccination, we have gone from about 1,800 deaths a day down to only about 100 deaths a day. It is a profound effect. So even though people are still getting it, they are much, much less unwell. The virus is circulating almost exclusively in those who are not vaccinated and largely in the younger group. It's mainly at the moment people between the ages of 12 and 19 who have the virus in the UK. The long-term consequences of this are going to be profound. Countries have sustained a huge financial loss, and this will need to be repaid over decades. Because of the interruption to travel, there have been massive supply chain issues, and this is going to affect businesses for many years to come, and it's going to affect some of the basic things. You're going to see things that you normally see on the shelves in the supermarket in less supply. Medicines, the way they move around the world has changed profoundly. There are going to be massive educational issues for the next generation, and this is particularly going to affect the more vulnerable people. I'm sure that if you go to a school like Grey, they'll put things in place to make sure that you still got a good education from home. If you have no computer, you live in a household where you share your bedroom with 6 other children, you're most unlikely to get any form of effective education from home. There's been a profound effect on healthcare overall. Remember, during coronavirus, the height of the pandemic, we did not treat many other patients who would have been treated. So we saw far fewer people coming to A&E with heart problems, long-term renal problems, out-of-control diabetes. These things were still happening, but the patients knew they were vulnerable and were frightened to go to the hospital because they'd be exposed to patients who had coronavirus. As a consequence of this, the estimation in the UK is that we're going to suffer from an extra 10,000 cancer deaths. In my field, in 2020, we did 106,000 fewer joint replacements than we did the year before. These are all patients who have end-stage arthritis of their joints who are suffering enormously. We estimate to get our waiting lists down to how they were prior to the pandemic will take about 10 years. Furthermore, there's been a lot of mental health issues amongst people. There's been huge dislocations in their lives, huge dislocations in their employment, and problems of isolation and interaction. Unfortunately, there's been a huge rise in domestic abuse throughout the world. Most people who are victims of domestic abuse find either school or work as their safe haven because they can get away from their abuser. People being stuck at home for months on end with their abuser has had terrible consequences for these people. What about the future? Well, in the near-term future, ironically, the COVID pandemic is most likely to lead to a flu pandemic. And the reason for this is an unintended consequence of lockdown. In lockdown, all communicable diseases decreased. So there's been a precipitous fall, for example, in sexually transmitted diseases in the UK. It's very difficult to give someone gonorrhea when you can't see them. Likewise, people couldn't give each other flu. And normally what happens is there's a flu pandemic that circulates around the world, going from a southern hemisphere winter to a northern hemisphere winter, kills about 500,000 people worldwide a year. But because people get the flu, they have a degree of immunity for the next year's flu. This hasn't happened last year, so we expect this year's winter to be particularly bad. The other thing to bear in mind is COVID is here to stay. It's never going to go away. But the virus will continue to evolve. People are very worried that because it evolves, the vaccines won't work as well. The experts out there believe that it will not evolve in such a way to make it resistant to the vaccines. However, they do believe that it will evolve in such a way that it will become less infectious and cause less severe disease. And this is what does tend to happen with many coronaviruses. However, at the moment, COVID is still a very, very, very serious healthcare problem, both on an individual basis and from a societal perspective. The only logical answer for people now is to get vaccinated. I cannot stress enough how important it is for you as an individual and your duty to your family, your duty to your loved ones, and the duty to society as a whole to make sure that you get vaccinated so that you're not unwell and so that you do not spread this to other people who are more vulnerable, who will become very unwell. The other thing as a society is we need to plan for the next big pandemic. As I said, we've had at least 8 pandemics in the last 100 years of various sorts. The next pandemic is just around the corner. We must not be caught in an unprepared fashion again. And lastly, we need to invest in medical research. In this situation, the boffins saved us. It's miraculous what they did. We need to make sure that we have the medical research infrastructure throughout the world so that we'll be ready for the next time we face a condition like this. So I think overall, the future is actually quite bright. We have done miraculously well in coming through the pandemic. We are not out of the woods yet. It's still going to take a long time and have profound effects. But if we work together, plan together, and all behave responsibly, we can contain this problem and learn from it. I hope you enjoy the reunion, and I hope that you have a great time for those of you who do manage to meet up with old classmates. And I certainly am looking forward to meeting up from my old classmates from my year in 1985. And lastly, just to reiterate, to Andrew and his family, our thoughts are with you, and we hope you make a speedy recovery.